Hello guys and welcome back to Count to 10. My name is Ani and on today's episode we're going to be starting our new series which looks at the basic principles of general pharmacology. In today's episode I'm going to be focusing on pharmacodynamics and in particular receptor theory and dose response curve. I hope this episode will serve as the building block you need to understand how drugs work as you go through the curriculum and learn about more and more drugs. If you haven't already done so, please check out my last episode, which I recorded with a current primary examiner, Dr. Anthony. I'm really proud of that episode. I think it's one of the best we've done so far on Count to 10. Anthony breaks down some really complex topics into some fundamental equations that help to understand how TCR modeling really works. In today's episode, we're going to go back to our normal structure. I'm going to go through the learning objectives first, and then look at the past SAQs regarding pharmacodynamics. There really isn't that many SAQs to go over, so it's more important that you know about the learning objectives well, because it is a topic that comes up not infrequently in Vivas, but more so, it's just important to know how drugs work, how to break them down into different classes, and understand their different mechanisms of action. Because that is really bread and butter of what we do every day, administering multiple drugs to patients in a very short amount of time. So you should know the pharmacodynamics of every drug you give really well. And with that said, let's dive straight in.
1, 2, 3, 4.
For the first learning objective, I'm actually going to combine two learning objectives into one. The first part being explain the concept of drug action with respect to receptor theory, enzyme interactions, and physicochemical interactions. And the second part being explain receptor activity with regard to ionic fluxes, second messengers in G proteins, nucleic acid synthesis, evidence for the presence of receptors, and the regulation of receptor number and activity. To start off, we can say that pharmacodynamics is the biochemical and the physiological effect of a drug. The way a drug can have an effect can be divided into four broad categories. The first category is chemical interactions. Here, the classic example is neutralizing reactions like antacids or chelating agents like sugammadex. The second category is enzymes. Here, a drug is either helping a substrate become a product or inhibiting a substrate from becoming a product. The classic example here is ACE inhibitors. The third category, and this is my category that I have in my list, and you don't need to include it in your list, you can have three categories instead, but for me, I put in voltage-gated ion channels. These are membrane-bound protein complexes involved in the conduction of an electrical impulse. So classically, this is how drugs like local anesthetics are working. In my mind, this is separate to how ligand-gated channels work, and this forms the fourth category and the biggest category when we think about drug action or mechanism of action, and that is receptors. The important thing to remember is when you get asked how drugs work, your mind will classically go to thinking about receptors only. But think about that question broadly and don't forget the other three categories on how drugs work. Yes, receptors is the biggest class, and it's the one that we're going to spend the most time on. So what are receptors? They're essentially protein-based moieties that contain a region that binds a natural ligand or a drug to bring about a response. We can further classify receptors into their location. This can be within a cell membrane where the ligand is poorly lipid soluble, or within the intracellular space where the ligand is lipid soluble. Now, the other way you can categorize receptors is by their mechanism of action, and this is the important categorization that you have to know. There are three main mechanisms of action. The first being altering ion permeability, the second being production of intermediate messengers, and the third being regulation of gene transcription. And we'll discuss each one of these in detail, starting with altering ion permeability. The way a drug can alter ion permeability is rather simple to understand. A drug binds to the receptor and can change its conformational state from open to closed or closed to open. In doing so, it either allows or inhibits the passage of ions down a concentration or a chemical gradient. The three families of ion channels that you need to know of in this class include the pentameric family, and these are receptors, as the name sounds, have 5 membrane spanning units. The classic examples being nicotinic acetylcholine receptors, GABA receptors, and serotonic receptors. The second family is ionotropic glutamate. These are usually excitatory neurotransmitters, and the classic example being NMDA or AMPA receptors. Then finally, we have the ionotropic purinogenic receptors. These are classically receptors that are activated by ATP and are involved in mechanosensation and in pain. The second categorization of receptors based on mechanism of action are those receptors that produce an intermediate messenger. An intermediate messenger is a membrane-bound system that transduces a ligand-generated signal on one side of the cell membrane into the intracellular signal transmitted by an intermediate messenger. Here, there are 3 really important intermediate messengers to know about. The first one, and the most important to know about, is your classical G-protein coupled receptors. Now, when I did my notes, there were around about 17 different types of G-protein coupled receptors. There's probably more by now, but the 3 most important to know of are GS, GI, and GQ. What makes a G-protein coupled receptor unique is that the ligand binds to the receptor and activates this G-protein trimer. In doing so, it has massive signal amplification, but it also has a downside of sometimes producing a concept known as tachyphylaxis if it's been activated repetitively. Involved in this signal amplification pathway, when you look at a GS protein receptor as an example, the steps involved include activation of adenylyl cyclase, which leads to a massive increase in cyclic AMP, which then leads to increased binding of protein kinase A, and this leads to major downstream effects that can either lead to channels opening, increase in gene activation, or increase in protein synthesis. In contrast, the GI protein coupled receptor does the opposite of a GS protein coupled receptor. Therefore, the way I remember it is that GS is stimulatory and GI is inhibitory. The GQ protein coupled receptor sits somewhere in between. The steps that occur when a GQ protein receptor is activated involve the activation of phospholipase C, which leads to the cleaving of PIP2 and the increased production of compounds called IP3 and DAG. And these can either do excitatory mechanisms or inhibitory mechanisms within the cell. Most drugs that we know of will work by activating the G protein coupled receptor, the classic examples here being opioids and adrenaline. Now, the second intermediate messenger that you need to know of is the guanylate cyclase system. This is a system that has a similar makeup to the G protein coupled receptors without the variability in the different types of G proteins. An example here being the effect of ANP or atrial natriuretic peptide, which works by the guanylate cyclase pathway. This pathway involves the activation of guanylate cyclase, which leads to the activation of cGMP, which phosphorylizes intracellular enzymes that lead to a downstream effect. The final intermediate messenger that you need to know of are tyrosine kinase receptors. These are receptors that are again transmembrane and lead to an activation of tyrosine kinase. The example here are drugs such as insulin and epidermal growth factor. Now, the final category of how receptors work based on mechanism of action is via the regulation of gene transcription. This is really straightforward, and it requires the activation of intracellular receptors that can have a direct effect on either DNA transcription or RNA transcription. The classic example here being your adrenosteroid hormones or your thyroid hormones. Now, with this mechanism of action working on gene transcription, you can assume that this takes the longest to work, but also probably has the longest duration of action. In contrast, altering ion permeability is the fastest to work, but also has the shortest duration of time, while the effects on intermediate messengers is in the middle ground. Now that's a very broad overview of the first two learning objectives. And just to summarize on how drugs work, we have the four classes being chemical interactions, enzyme action, voltage-gated ion channels, and then receptors, with receptors being the biggest way that drugs work. Receptors can then be broken down into their location or grouped on mechanism of action. And if you group them on mechanism of action, this can be further broken down into altering ion permeability, production of intermediate messengers, or the regulation of gene transcription. So this brings us on to our next learning objective, which is to explain the law of mass action and dynamic equilibrium and describe receptor affinity and dissociation constants. To understand this learning objective, we can use a basic equation which describes how a drug and a receptor becomes a drug-receptor complex. We can then further say that the rate at which a drug and a receptor become this complex can be said to be a forward rate constant, K1, and the rate at which a drug-receptor complex becomes back into a drug and a receptor can be a reverse drug constant called K2. If we then take this fundamental equation and apply the law of mass action to it, which basically describes that the rate of reaction is proportional to the concentration of the reacting agents, such that the rate of the reaction going forward will be increased if we have more drug and receptor, and the rate of reaction going backwards will be increased if you have more drug-receptor complexes. Furthermore, at equilibrium, both rate constants will cancel each other out, so you'll have an equilibrium of the drug-receptor complex and the drug and receptor by itself. This is what we refer to as the equilibrium constant, and you have an equilibrium dissociation constant called Kd, and you have an equilibrium association constant called Ka. If Ka is increased, then Kd would be naturally decreased, and if Kd is increased, then naturally Ka will be decreased. Now that might sound a bit complex, but in plain language, all we're saying is if the association constant is high, we're getting more formation of the drug-receptor complex and less formation of the drug and receptor by itself. The next logical question to ask is, why is this law of mass action important to how drugs work? Well, the reason it's important is because we initially thought the intensity of a drug effect was proportional to the receptor occupancy. In other words, if we gave more drug and they binded to more and more receptors, we thought that this would lead to a higher magnitude of effect, and this was known as the receptor occupancy theory. Now, we currently know that is not true, and we have a different way to think about how drugs and receptors work. Our current way of thinking is that a receptor exists in equilibrium. There's some receptors that stay in the active state and some receptors that stay in the inactive state, and the effect of drugs can either shift that balance to one way or another, or have no effect and keep the equilibrium the same. This way of thinking allows us to then describe drugs as those that are agonist, therefore shifting the equilibrium to more active state, or antagonist, that do not alter the equilibrium at all. And this terminology that we use to describe drugs brings us on to our final learning objective, which is define and explain dose-effect relationships of drugs with reference to graded and quantile response, therapeutic index, potency and efficacy, competitive and non-competitive antagonists, partial agonists, mixed agonist-antagonist, and inverse agonists, additive and synergistic effects of drug combinations, and describe the efficacy and potency with reference to dose-response curves. This again seems like a very loaded learning objective, but really it's just going through some basic definitions that we've already touched on and some graphs. Using these two terms that we've just introduced, agonist and antagonist, we need to be able to describe the effects of all drugs, so therefore we need to be able to categorize agonists and antagonists. The way we do this is by using two fundamental properties of every drug. And to do this, I'll use an analogy of a lock on a door and a key to open that lock The way we derive different categories of agonist and antagonist goes back to two fundamental properties of every drug. The first property is described as the affinity of that drug. The affinity describes how well that drug binds to the receptor, i.e., does the key fit in the lock? The second property is the intrinsic activity. This is also known as the efficacy, so it's the same term, and you might see it referred to as efficacy or intrinsic activity. The intrinsic activity describes the magnitude of effect once the drug is bound to the receptor. So once the key goes into the lock and you know that it fits into the lock, does it open the door fully? Does it open the door partly? Or does it not open the door at all? And we can describe this response on a scale of 0 to 1, with 1 being the full response, so the door being opened fully, and 0 being no response, so the door not being opened at all, and between 0 to 1 is the door being partially opened. When we use these two properties, we can then describe agonist drugs as either being full agonists, those are the ones that can generate a maximal response, so the key fits into the lock and the door opens fully, and so therefore their intrinsic activity is equal to 1. Or we can have partial agonist. This is where the key fits into the lock, but the door does not open fully. It sits somewhere between 0 to 1. And the best example here is buprenorphine. A side note on partial agonist, and really important to understand clinically, is that a partial agonist at low doses can be synergistic with other agonists. Therefore, if you have more than one agonist working with a partial agonist, at low doses, it can help to open that door fully. However, if you give the partial agonist at a very high dose, what it will do is it will stop other agonists from being able to bind to that lock, and that door will not be able to open. Therefore, at high doses, a partial agonist can start to work like an antagonist. And this is some, but not all of the reason why we use drugs like buprenorphine for opioid withdrawal programs. Now going back to different types of agonist, the third agonist to know of is an inverse agonist. This is where the key fits into the lock, but instead of the door opening, it actually flings back on you. So it's not that the door stays closed, it's that instead of doing what it was supposed to do and opening up, it actually does the opposite and flings back on you. And an example of drugs that have an inverse agonist effect are drugs like flumazenil and atropine at low doses. And you might have seen this when you give atropine, say, 100 mics instead of giving 300, 600 mics, the patient actually becomes bradycardic instead of becoming tachycardic with what you think the effect of atropine should be. In these cases, we say that the intrinsic activity or the efficacy of the drug lies between 0 and -1. So this is how we classify different types of agonists. The way we classify antagonists is that the door doesn't open or fling back on you. It just stays there. And so the intrinsic activity of an antagonist is 0. The classification of an antagonist are those that are either reversible or irreversible. Reversible antagonists can be further classified into competitive or non-competitive. Competitive antagonists are those that where a drug competes with an agonist for the same receptor. So you might have two different types of keys, one being the agonist and one being the antagonist. Both of them can fit into the lock and either open the door being the agonist or do nothing to the door being the antagonist, and they're both competing for the same region. The one that wins is based on the concentration of which one is higher, going back to the law of mass action. An example of this is a non-depolarizing muscle blocker. Here, these are the antagonists, and the natural agonists are your acetylcholine. Initially, when you give the non-depolarizing muscle blocker, the effect of the drug outweigh the effect of the acetylcholine because they outnumber the acetylcholine. As the drug starts to move away from the neuromuscular junction, the effect of the acetylcholine starts to return, and that's why the patient starts to move after a certain period of time again. On the other hand, non-competitive reversible antagonists do not bind to the same site as agonists. So here you have two keys, the agonist going into the lock, and the non-competitive antagonist does not go into the lock. It goes to a different site. And by going to a different site, it alters the way the agonist key works on the door. Here, the most important example to remember is ketamine, and it does this through manipulating the NMDA receptor. The key thing with this type of antagonism is if you give more agonist, it does not take away the effect of the non-reversible competitive antagonist. Therefore, it is not concentration dependent. Then the other category of antagonists are the irreversible antagonists. And as the name sounds, these are drugs that have an irreversible effect. They can either bind to the same site as an agonist or a different site. The key thing here again is that the effect of the drug does not get changed by increasing the concentration of an agonist. An example of this type of drug includes aspirin. Finally, we have one more classification of a different type of way a drug works which does not fit either agonist or antagonist, and this is referred to as an allosteric modulator. Allosteric modulating drugs have reversible activity and bind to a site that's distant to an agonist. The key characteristic of an allosteric modulator is that if it was bound to a receptor by itself, it wouldn't have any discernible effects. It's only when another agonist is bound to it, it either increases the effect of the agonist or decreases the effect of an agonist. If it increases the effect of an agonist, that's referred to as a positive allosteric modulator, and an example here being benzodiazepines on the effect of GABA. Or if there is a negative effect on the agonist, that drug is referred to as a negative allosteric modulator. Those are the three key terms you need to be able to understand to describe any drug. So are they an agonist, are they an antagonist, or are they an allosteric modulator? And the two properties that we go back to refer to is the affinity and the intrinsic activity. Now let's pull all this information together and put it in the context of dose-response curves. When we talk about dose-response curves, there's two curves to know of, and it's a slight difference but a very important difference, and you can easily be tricked on that in an SAQ or in a Viva setting. The difference is that there's two dose-response curves that we talk about. We either talk about a quantile dose-response curve or a graded dose-response curve. A quantile dose-response curve is derived from the population. It describes the drug dose and the frequency of a quantile response. A quantile response is an all or nothing response. That is, either someone in the population has a response or they do not have a response. Normally in a population, the quantile dose-response curve follows the normal distribution of a bell curve. If we do a logarithmic derivation of that normal distribution, we then get the classic sigmoidal curve, where the x-axis is the drug dose and the y-axis is the percentage of the population having a response. This type of curve is really important when we think about the safety of a drug, and so when you think about quantile dose-response curve, think about safety, because it allows us to derive some parameters such as effective dose, the lethal dose, and a margin of safety. The effective dose, or the ED50, would be the dose at which 50% of the population is having a response. The lethal dose is calculated using a therapeutic index. The therapeutic index is used to evaluate safety and the usefulness of a given drug. The way it's calculated is that it looks at the lethal dose of a drug at 50% of the population, referred to as LD50, divided by the effective dose of the drug for 50% of the population. If that number is high, so your numerator is high and your denominator is low, that means that the drug has a high therapeutic index. And you want all your drugs to have a high therapeutic index. That means that you have to give a very high accidental overdose to have a lethal effect on a person. Now, on a side note, the LD50 isn't calculated by giving the lethal dose to a person and seeing if 50% of the population die or not. It's calculated using rat models by giving them gradual increases of a drug until there's a lethal effect. Now, margin of safety is another term that we commonly use to see how safe a drug is. And that also can be derived from the quantile dose response curve. The way that it's calculated is that it looks at the LD for 1% of the population, so the lethal dose for 1% of the population, divided by the effective dose for 99% of the population. So what this graph is looking at is the comparison at the extremes. The smaller the number you get, the less margin of safety you have with the drug. And we say that the drug is dangerous when the margin of safety is less than 1. So that's all I want to say about the quantile dose response curve. It's good at figuring out effective dose, lethal dose, therapeutic index, and margin of safety. Now let's look at the graded dose response curve. The difference with the graded dose response curve is that it's taken from an individual, so it describes the relationship between the drug effect in an individual and the drug dose, where the drug effect is on the y-axis, and we can say that the drug effect can be 50%, 100%, 25%, whatever, and the drug dose is on the x-axis. The classic shape of this curve is that it's a hyperbolic shape. So as you get to more and more of the drug being given, the effect that you're getting from that drug is less and less, until you eventually reach the max effect of the drug. What we normally do with this curve is that we again log transform it, and it becomes a sigmoid shaped curve. And as we know from our oxygen dissociation curve, which is another sigmoid shaped curve, the biggest change occurs in the middle linear portion of that curve. And if we translate this into talking about drug effect, we can say that giving between 20 to 80% of the drug dose produces the biggest effect on an individual. If you give too much of that drug past that, what you're getting is less of that desired therapeutic effect of that drug and more of the unwanted side effect of that drug as you give more and more past that 80% range. The other important aspect of this graded dose response curve is that it allows us to compare the effects of different drugs and see the effects of agonists and antagonists on the same graph. So if we give the same person two different drugs and we plot this on the graded dose response curve, which has been log transformed, what we can then compare is the potency of that drug. For example, we give the person drug A being fentanyl and drug B being morphine. What you'll see is that you'll need a much lesser dose of fentanyl to have an effect on that individual. Therefore, what we can interpret is that the potency of fentanyl is higher than the potency of morphine. The other thing these graded dose response curves allow us to analyze is to see if a drug is a full agonist or a partial agonist. If we give two different drugs and one drug never reaches its maximum effect and the other drug does reach a maximum effect, then we can compare these two graphs and say that one drug must be a partial agonist and the other drug is a full agonist. And that's exactly what you see when you give someone buprenorphine versus morphine. You can use these same principles to then see what happens when you give someone an agonist and a competitive antagonist or a non-competitive antagonist. With a competitive antagonist, we can say that both the drugs are trying to go for the same lock. So you could imagine that if they're both trying to compete for the same site, if you give more competitive antagonist, you're decreasing the potency of the agonist. When we describe this in the graphical terms, we say that the addition of a competitive antagonist shifts the graph of an agonist to the right. In other words, it's decreasing the effective concentration of the drug, or the EC50, to the right. In contrast, when you give someone a non-competitive antagonist, the non-competitive antagonist is not fighting for the same lock as the agonist. The agonist key can still go into the same lock and the non-competitive antagonist key binds somewhere else. Therefore, the starting point of the graph doesn't change. It doesn't shift to the right. However, the maximum effect that the drug can produce is reduced. Therefore, the effective concentration for 50% of the effect is lowered. So with the competitive antagonist, the EC50 is shifted to the right, but it stays at the same level. With a non-competitive antagonist, the EC50 is not shifted to the right. It stays in the same area, but is lowered because the max effect of the drug is also lowered. And this leads us nicely on to talking about our only SAQ for today, which was asked in 2020, second sitting, and has been repeated twice, which was, using opioids as examples, describe and illustrate with graphs what you understand by the terms potency, efficacy, partial agonist, competitive antagonist, and therapeutic index. The last time this was asked, it had an 86% pass rate, and so we'll go through the examiner report and the model answer in a second. I'll just quickly mention there is another question that talks about the quantile dose response curve in the context of rock uranium, but it requires some underlying knowledge of non-depolarizing muscle agents, so I'm not going to discuss that today. However, the concepts of what we spoke about with the quantile dose response curve still apply in the same way to that question. Going back to the first question, the key thing in the examiner report was to provide basic definitions and examples to support the definitions and draw and label the graphs to demonstrate the key points. The most important point was to draw the correct log dose response curve to demonstrate those key points and correctly use opioids as examples, as asked for in this question. And I think opioids lend themselves well for these types of graphs and these types of definitions in particular, because we have a known agonist, we have a known partial antagonist, and we have a known competitive antagonist. So looking at the model answer, you can quickly just rattle off the definitions and then draw your graph. The only clarification I'll say with the model answer here is that I've been using the graded dose response curve to use as an illustration with the same person how we can differentiate between two different drugs, i.e. the potency, the effect of a competitive and a non-competitive antagonist, and the effect of a partial agonist. What you should be using is the quantile dose response curve when you want to accurately measure the potency of a drug, because you want to use the whole population and see where 50% of the population has an effect, because you just don't want to use one person, i.e. a graded dose response curve, because that's going to be an inaccurate representation of what the potency of the drug is when you compare with a standardized point. The other trick is when you're trying to show off the difference between a full agonist and a partial agonist, that has to be done on a graded dose response curve. Because remember, on a quantile dose response curve, it's an all or nothing response. It's not actually measuring what the maximum response is. To see the maximum response, you need to do it on an individual and therefore use the graded dose response curve to be able to differentiate between a full agonist and a partial agonist. So then going back to some quick definitions, we described that potency was the measure of the dose of the drug required to produce a given effect. We can compare these two by ED50s related to different drugs. And the classic example here, because it's easy to remember, would be having fentanyl and morphine, and knowing that morphine is 100 times less potent than fentanyl. So you could use some easy numbers like 1 mic of fentanyl versus 100 mics of morphine, or 0.1 milligram of fentanyl and 10 milligrams of morphine. Either way, you just draw the same sigmoid curve and you just show that the ED50 is different for fentanyl and morphine. The second term to define here is efficacy, which has lots of various definitions in multiple model answers, but to me it's just the maximum effect produced when the drug binds to a receptor. So that's graded as 0 to 1, so looking at the intrinsic activity of the drug. And we can say by definition, a full agonist has maximum effect of the drug, therefore its intrinsic activity is 1, while an antagonist has an intrinsic activity of 0. Now I've seen in some model answers efficacy being described as both the affinity and the intrinsic activity, but I just back propofol dreams on this one and use that previous definition. Then the next definition is of partial agonist. So here, a partial agonist again refers to an intrinsic activity between 0 to 1. And again, the example I would use is buprenorphine, and I'd compare this to fentanyl. The caveat here being, you have to use a graded dose response curve because you're looking at an individual to see what the max effect is, not an all or nothing response that you see with a quantile dose response curve. The final few terms are competitive antagonists, which we've already talked about as being an intrinsic activity of 0. And when you're showing this, you would have fentanyl versus fentanyl with naloxone, and this would shift the curve of fentanyl to the right, so moving the effective concentration, if you're using a graded dose response curve, to the right, but not changing the max effect the drug can reach, because with the competitive antagonist, if you give more of the agonist, you can overthrow the effect of the competitive antagonist. Finally, you have the definition of therapeutic index, which we've said again needs the quantile dose response curve. And here you're looking at the lethal dose for 50% of the population divided by the effective dose for 50% of the population. And here you'd be using animal models to figure out the lethal dose for 50% of the population. Or if you want to do it in humans, you can do the toxic dose in 50% of the population divided by the effective dose in 50% of the population. When we talk about the toxic dose, we pick a desired toxic effect which doesn't have too much long-term negative effect. So it might be something like decrease in rest rate, something that can be managed quite easily, and then you compare it with the effective dose. The key thing when you're drawing this graph is you don't need to know the exact numbers, but you need to know that if you have a higher number, this suggests a higher therapeutic index, and that the lethal dose or the toxic dose should be well above whatever you have as the effective dose for 50% of the population. The wider that separation, the wider the therapeutic index, and the higher the safety of that drug is. Just don't confuse that term with margin of safety, which looks at the lethal dose for 1% of the population divided by the therapeutic dose for 99% of the population. So that's a different term separately, so just use the term safety in general, not margin of safety. So that brings us to the end of today's episode and the end of the first topic in our series of General Pharmacology Principles. As always, if you have any questions, feel free to email me at anirudh at Sweet Dreams Anesthesia. We'll be back next episode looking at pharmacokinetics. Until then, best of luck with your studying. I'll catch you next time on Count to 10.